Hello, everyone. Welcome. My name is Max Orr, Executive Director of Carolina Public Humanities, and it's my pleasure to welcome you to this Humanities in Action event. We're going to be looking at healthcare in the new Biden administration. I want to thank a bunch of people to begin, but first I want to start by thanking Paul Bonici for the wonderful music. We were talking about what do we play before this particular event, and when you look up songs with medicine, healthcare, things, they're mostly songs about drugs. So we found some good ones here. The great Dr. John there at the end, and of course Robert Palmer before that, both of whom have left us. But rest in peace and welcome all of you. Before we begin, I want to thank a few other people. Of course, Paul Bonici, who I did, our Carolina Public Humanities behind the scenes person. Also behind the scenes today are Vicki Breeden, who's watching remotely from the office, from the main base, and Brian Ensminger helped all of you come in. Of course, everyone at Carolina Public Humanities is doing great work keeping us going in these weird and odd times. I'm joining you from my daughter, who no longer lives in Chapel Hill, from her former bedroom, which has become my COVID office. Welcome, all of you. Before we begin, I want to thank a few other folks. Carolina Meadows, a retirement community at Chapel Hill, has been a wonderful supporter of our programs, both our public programs and of course our programs for Carolina K-12 and teacher workshops. The Cotton Merca Group in Morgan Stanley is a wonderful partner of ours, especially promoting our Carolina K-12 programs for teachers, very important work. And of course, the General Alumni Association, which has been doing some really fantastic work with us throughout all of our career and helping to publicize and promote our programs and putting on programs, especially our Humanities in Action, which you are here watching today. I also want to tell you about a few upcoming programs we have. I know that you saw in the opening slideshow, you saw perhaps some of our upcoming programs, but we do have a wonderful, Gerhard Weinberg is joining us again for this weekend for World War II in the Pacific. We still have some room in that. Of course, we have plenty of room because we're all virtual. But I also want to remind folks that we have another weekend seminar coming up on March 5th and 6th, the Global Challenge of Religious Freedom. We'll be looking at that from the perspective of France, the United States, and China. But of course, we'll be delving into the issue in a philosophical sense and sort of thinking about the concept in general. We have other wonderful weekend seminars happening later in March and in April, and we'll let you go to humanities.unc.edu to look at those. But I also want to remind you folks, tomorrow is our second of our Lunch with Friends and Strangers, the biography program. And we're going to be talking with Dr. Charlene Register, and we're talking about Dorothy Dandridge. So if you like wonderful singing and acting from the mid-20th century and a remarkable person, come on by for Lunch with Friends and Strangers. And again, you can find that at the website that Paul has put down there in our chat box. And finally, of course, keep in mind that Humanities in Action continues. February 24th, we'll be working on the history of Jim Crow laws in North Carolina. March 10th, we'll be looking at a really interesting talk on gig economies and how they help promote or propel radical movements. And one that is not on our website yet, but we're really very much looking forward to that, is Ashley Anderson will be joining us on March 17th to be discussing just what happened with race in the election last year. And we'll have more information on the title on that and whatnot and put that up on our website soon. If you have signed up for a season series pass, that last talk is included in your price. So keep all of those in mind. Go to humanities.unc.edu to check out our upcoming programs. And also bear in mind, folks, that we're doing our work on all fronts, both this public programming front, which you are here, welcome, we're delighted to have you. But keep in mind, we're also doing incredible work with teachers throughout this whole very difficult period, continuing to hold virtual events for teachers to train them up and get them continuing education units, as well as continuing to reach out to our community college partners to provide great content from UNC faculty and scholarship, and spreading it throughout the state in a variety of communities. So I just want to, of course, remind you folks, if you'd like to help us with our mission, these are difficult times for everyone. We certainly would be grateful for any donations you can give to us. We'll put our donating link in the chat box down here. And of course, remember that all donations are appreciated and all are tax deductible. That's my opening, but let's get to the moment. We're really, really excited to welcome back a friend to the Humanities program, and someone we always ask them kind of do the same thing, a little different here and there, and that is John Oberlander. Hello, John. John is a political science and the chair of the Department of Social Medicine in the UNC School of Medicine. And we're going to put down a little bit of information on John in the chat box down here, so you can take a look at his whole CV and get a sense of what he's done and where he's been. I will say he is, in fact, a product of the University of North Carolina before he went on to do some higher degrees elsewhere, Yale University, and then came back to us. So we're lucky to have you. And one final thing I just want to say, I think that the whole notion of a Department of Social Medicine is a real sign of the cutting edge approach that UNC is taking towards medicine. It incorporates social sciences and the humanities in understanding the human body and how to make it better and how it fits in the whole society. So it's a cool department. And we have, well, I'm going to go ahead and say, we have the coolest guy in that department, the chair of that department, John Oberlander. John, welcome, and thank you for coming back and doing this with us.
Thanks for having me. I don't think you're the coolest one, but maybe the only one who would give a talk right before an ice storm.
There you go. Well,
I'm very popular right before natural disasters. I'm not sure
what could
why.
be cooler than ice, right?
Ah, yes, yes.
We're too quick. I'm going to get out of here, John. I'm going to let you take over. Ladies and gentlemen, please welcome John Oberlander.
Thank you. And I'm gonna let's see, try and share a screen here if I can. Okay. All right, hopefully you all can see that. It is great to be back with Humanities in Action. Great to be with you all. Hope everybody stays warm and safe in the coming days. And by the way, I am very happy if anybody ever wants to talk about the Department of Social Medicine. We are a very unique place. There are only about a half a dozen departments of social medicine in North America. And we play a very unique and I think incredibly crucial role in the medical school here at Carolina, and I can talk for hours about that, but I won't. All right, so let's see here. Oh, yes, thank you for that. So let me just start with the observation that we've got a new day in healthcare and a new day in American politics. And what I want to do is, first of all, talk about where we are right now in US healthcare reform. What can we say about the Affordable Care Act? How do we evaluate it as we go into this new administration? And then I want to talk specifically about the Biden administration and what their options are for healthcare reform, what they can do, what they probably can't do, and what the future looks like. And I'm going to leave plenty of time for questions. So away we go. So let me start off with a brief history of the last decade in American health policy in 4 slides. So if we go back to 2010, there's Barack Obama signing the Affordable Care Act, which, was an enormous deal, particularly after a century of often failure, not always, but often failure in healthcare reform. The Affordable Care Act passes in 2010, and it is the most important healthcare legislation in the United States since Medicare and Medicaid were enacted in 1965. And so it's passed in 2010, and a lot of people thought that was, well, maybe a bit of a fairy tale. Something seemingly impossible had happened, and the American healthcare system wasn't perfect by any stretch, and the Affordable Care Act wasn't going to fix everything, but maybe we were going to look more like France or Germany or the Netherlands and other countries that have universal healthcare, and we were going to go down that road, and over time we would improve the Affordable Care Act and build on the Affordable Care Act and get closer and closer to the international standard, which is universal health insurance. Then, of course, we had another election a few years later, and Donald Trump wins the presidency in 2016 and doesn't like Obamacare. Obamacare is, well, the embodiment of Barack Obama, his signature policy achievement while president. And Donald Trump campaigned on repealing Obamacare. Republicans have been talking about repealing the Affordable Care Act ever since it was enacted. And Republicans in Congress, Republicans at the state level, Republicans running for president, and they weren't able to do it in between 2010 and 2017 because Barack Obama was in the White House. But when Donald Trump is elected, you get a Republican president with a Republican majority in the Senate and a Republican majority in the House. And it seems like they're going to write a new chapter or maybe unwrite a chapter in American health policy and repeal Obamacare. I'll give you a second to absorb this one because, as I always say, political cartoonists are the best sources of analysis in American politics. And this cartoon sums it up, which is repealing Obamacare proved to be much trickier than a lot of Republicans thought. And so even though Republicans had the White House, even though they had majorities in the House and the Senate, they were unable to repeal the Affordable Care Act in 2017. And it turned into really a sort of political disaster for the party, and Republicans end up losing their congressional majority in the House in the 2018 midterm elections, in no small part due to the controversy over repealing Obamacare. And then, of course, we get the 2020 elections, and Joe Biden wins, and it's a restoration. Joe Biden being the vice president for Barack Obama. This is a restoration of the Obama-Biden administration, and the return to office of somebody who obviously supports the Affordable Care Act, wants to build on the Affordable Care Act. And so that's sort of where we've been on this topsy-turvy roller coaster over the last decade. So before I get into the Biden administration, I want to talk for a bit about the Affordable Care Act and how well it's performed and what it's done well and what it's not done so well. And, you know, it just passed the decade mark last March, actually. It was obscured by COVID and the pandemic, but about 11 months ago was the 10th anniversary of the enactment of the Affordable Care Act. I chose a birthday cake for 10 because the birthday cakes for 11 aren't as good online. I'm not sure why, but we all know that birthdays with a 0 in the second digit are a time for reflection. So what do we know as the Affordable Care Act next month will hit its 11th birthday? What can we say about its performance? And I really want to evaluate it in terms of 3 dimensions: access to health insurance, effects on the health of Americans, healthcare spending. Oh, 4 dimensions. Look at that, a bonus dimension. And finally, it's politics. How is it done politically? So let's take a look at those. So the central aim of the Affordable Care Act was, of course, to bring down the uninsured population, to cover more Americans. We were and are the only rich democracy in the world that does not have universal health insurance, that has a large uninsured population. And back before the Affordable Care Act was enacted, you can see we had, between 46 and 47 million people by this metric without any health insurance. And the goal was not to get universal health insurance, because Obamacare was never universal, but it was to reduce that uninsured population. There are a lot of things that have gone wrong with the Affordable Care Act. Some of those wounds are self-inflicted. There are problems that we'll talk about with the law. Some of the implementation of the law, I think, was quite poor. And then some of the problems and limits of the Affordable Care Act come from the outside, political pressures on it, opposition to it, and so forth. Lots of things, though, have gone wrong, whatever the source. And yet you can see the Affordable Care Act really did have a pretty profound effect, in coverage. So about 20 million Americans gained health insurance, and gained health insurance in a relatively short period of time. The Affordable Care Act's major coverage provisions went into effect right here in 2014. So you can see once those major provisions went into effect, we really brought the uninsured population down substantially. And that's really important. There were a lot of Americans who, before the Affordable Care Act, didn't have the financial means to get coverage, and the Affordable Care Act gave them financial assistance if they were low income or of modest income, and helped them buy private insurance, or if your state expanded Medicaid, help them get into Medicaid. There are a lot of North Carolinians and a lot of Americans across the country who couldn't get health insurance before the Affordable Care Act because they had a pre-existing condition. And before the Affordable Care Act, it was legal for private insurers to discriminate against people with pre-existing conditions. And if you had cancer or even a illness far less acute, far less severe, they could charge you very high premiums or exclude you from coverage altogether if you were shopping for insurance on your own, if you didn't get it through work. And that was a very substantial barrier for a lot of folks. And the Affordable Care Act really did a lot to help those folks. It it banned discrimination on the basis of pre-existing conditions. It regulated private insurers in a way they had never been regulated before in the United States. And by doing so, it created access to health insurance. Having said that, that's the glass half full. I don't know how much this glass is, like 3/4 full. So let me add a little more water. Get it down to half full. So that's the glass half full. The glass half empty is, well, after all this and all the promises of the Affordable Care Act, look, we still had, as of 2019, over 28 million people who are uninsured. So there's still a lot of people in North Carolina. It's over 1 million. Nationally, you can see what the number is. A lot of Americans, a lot of people living in this country still don't have health insurance. And that is an indication of some of the limits of the Affordable Care Act and some of the problems with it. One of those problems you can see right here, this is from the National Health Interviews Survey, which is a huge national survey that's done by part of the CDC, the Centers for Disease Control, and is one of the sort of gold standard surveys. And it's this is done every year, and you can see they ask adults, okay, who are uninsured, why are you still uninsured? We have this law, why are you still uninsured? And you can see 74% of them said that it's because health insurance was not affordable. Well, that's a problem. We got a law called the Affordable Care Act. And if a decade after that law is passed, 3/4 of the uninsured are saying that health insurance is not affordable, then we got a major problem. Now, why could that be? Well, it may be that people aren't aware of the financial assistance that they're eligible for. And we know this to be true. We know this from other studies that many Americans who would be eligible for financial help if they applied just don't know that they're eligible for those subsidies to buy private insurance under the Affordable Care Act. They just don't know it. And a lot of people lose out because of that. So that's certainly the case, but it's not the only reason the 3/4 of people who are uninsured are saying health insurance is not affordable. Another reason they're saying it is this chart right here. So let me take a step back and remind you that under the Affordable Care Act, if you're uninsured, you can go on to what's called the marketplace with a capital M. And for much of the country, that means going to healthcare.gov, which is run by the federal government. Or if you're in a state like California or Connecticut, you can go onto their state website. And if you're uninsured, you can go on there and then you can look and see which private plans are available. And there are different levels of coverage. And you will get a subsidy based on your income. The lower your income, the higher the subsidy. And you can choose what kind of plan you want. And it comes with different combinations of premiums and deductibles and so forth. So what I did is, this is not for this current 2021, it's for last year. I plugged in, okay, Chapel Hill, let's take somebody age 30. I was age 30 a really long time ago, but we want people who are age 30 to sign up for health insurance via the Affordable Care Act because they're younger and healthier. And we want to balance out those insurance pools. So I took somebody at age 30 and I put in different incomes. And I said, what is their annual premium going to be? So somebody making $20,000 could get health insurance for about $50 a month through the Affordable Care Act. $600 a year. I mean, that's pretty good. That's a lot less than I pay my cell phone company. So that's pretty good value for health insurance. But look what happens as I go up the income scale. Somebody makes $40,000 in Chapel Hill. That's a good income, but they're certainly not rich. Think about their food costs, their housing costs, their utility costs, and so forth. They would face a premium almost 10% of their income, $3,900, a deductible of $3,000, and out-of-pocket maximum, that means the maximum including the deductible, the co-pays, the co-insurance that they would have to pay for going to the doctor in the hospital, $8,150. I think a lot of people in this income range would look at this and say, why should I spend $3,900 a year in premiums for a plan that has a $3,000 deductible? So I'm on the hook basically for the first $7,000 here. And I only make $40,000 a year. That's a huge chunk of my income. And what it underscores is the Affordable Care Act is not a great deal. If you're middle class and you've got to buy coverage through these marketplaces, these online marketplaces, if you don't have insurance through work, and you're middle class, the subsidies are limited. It's just not a very good deal. And that makes it unaffordable, particularly if you're older. So then I plugged in somebody who's twice their age 60, and I put in $50,000. Their annual premium is almost $12,000 a year. That's 25% of their income. Very few people can afford that. Very few people. So the Affordable Care Act has done a good job in terms of expanding access to health insurance, but it still has an affordability problem. And that explains why we still have, in part, 30 million people nearly without health insurance. Oh, there's one other thing. Let me go backwards. I forgot to say this. This is the problem of talking without any notes, is it is a natural flow, but then I just naturally forget to say things. All right, so notice I don't have 2020 on here. We don't know yet what the impact of COVID is on health insurance. We suspect that the uninsured population went up in 2020. Millions of Americans obviously were out of work. But the increase in the uninsured population may not be as big as we would assume. Why is that? One, the Affordable Care Act is there as kind of a safety net. So a lot of people who lost their health insurance through work were able to get coverage through the Affordable Care Act. The second reason is a lot of people who lost their jobs actually didn't have health insurance. They were already uninsured. So they may be in a very difficult predicament right now, but they're not an increase to the uninsured population. And finally, a lot of businesses helped along by federal aid. Rather than fire workers, they furloughed workers. And when they furloughed them, in some cases, they kept their health benefits going. So there was probably an increase in the uninsured population, but we don't have a good idea of the size of it. And in fact, it's really hard to get an accurate measurement because of COVID. The way that we do these kind of surveys where we figure out who's uninsured, in 2020, it was a huge mess. And so we just don't have accurate data yet. So stay tuned for that. All right, so another reason why a lot of Americans say that health insurance is not affordable is their states didn't expand Medicaid. Remember, originally under the Affordable Care Act, the vision is all states were going to expand Medicaid eligibility, and anybody who was uninsured, who made up to 133% of the federal poverty level, so right now that would be roughly $15,000 to $16,000 for an individual, they were going to be eligible for Medicaid. It didn't matter their demographic category. Historically, Medicaid eligibility was premised on demographic category. You had to be a child, you had to be a pregnant woman, somebody with a disability, or you didn't qualify. And the result is we had a lot of low-income Americans who didn't qualify for Medicaid because they didn't fit those demographic categories, particularly men without dependent children. So the Affordable Care Act said, no, we're going to go with one income-based standard. But the Supreme Court issued a ruling in 2012 that made Medicaid expansion optional, essentially, for the states. And when they did that, most of the states expanded, and you can see here, I'm terrible at colors, so I don't really know what to call this. Maybe people can put their nominations for it in chat, but this magenta off purple, I failed art in elementary school, so I'm the wrong person for this. So all these states expanded. And there was some bipartisanship on this. Every single Democratic-run state that had a Democratic governor and a Democratic majority legislature expanded Medicaid eligibility under the Affordable Care Act. And some Republican states did too. Under Governor Martinez in New Mexico, Governor Brewer in Arizona, Governor Kasich in Ohio, Governor Christie in New Jersey, all Republican governors, and there are more, they expanded Medicaid as well. But we're left with roughly a dozen states that have not expanded Medicaid. Those states all have one thing in common. They all have either a Republican governor or a Republican majority legislature. So while support for Medicaid expansion was to some extent bipartisan, opposition to it is very partisan. And Medicaid expansion essentially became a front in the broader partisan war over Obamacare. And when it became a partisan issue, partisan politics were involved, a lot of Republican-run states said, we're not going to do this. There is also a geographic pattern. I'm not a geographer, I'm a political scientist, but I think I can identify a geographic pattern. And you'll see that many of the states that have not expanded Medicaid are concentrated down here in the South. And there's a sort of disquieting reality to this, which is most of the states of the original Confederacy, if we go back to the 19th century, most of the Confederate states have not expanded Medicaid. And that is a disturbing pattern. It tells you something about the politics in our part of the country. It probably tells you something about race and the role of race in politics and in Medicaid expansion. And there's some political science studies looking at this, about how race and racism affect public attitudes on Medicaid expansion. But one thing that I think is very easy to relate to is just a sense, if you're going to expand Medicaid eligibility, the question that people are going to ask is, who is that going to? Who is that for? And in some states, the question of who it's going to, people have in their mind the other, somebody else. And so it ties in, I think, to politics of race and to patterns of racism. Because if you look at this concentration here, there are a lot of other very conservative Republican states that have expanded Medicaid, but less so here in the South. So in any case, the fact that we did not expand Medicaid in these 12 states blew a hole in the Affordable Care Act for low-income persons. So if you're living in North Carolina and you weren't previously eligible for Medicaid before 2010, say you're a single adult and you don't have any dependent children, non-disabled, and you make $6,000 a year, you're not eligible for Medicaid right now because we didn't expand it. And you're also not eligible to go into the health insurance marketplace and get subsidized coverage, because when they wrote the law, they didn't anticipate that states wouldn't expand Medicaid. So there's no sort of provision that allows you to go buy private health insurance with subsidies. So to put that in English, we are subsidizing people who make $30,000, $35,000, $40,000 a year. They don't get a huge subsidy, but they get some subsidy to buy health insurance through the Affordable Care Act. But in the states that didn't expand Medicaid, individuals who make under roughly $12,000 a year, they have no options. They're eligible for no help whatsoever. And that means that these states have a very high uninsured rate, including North Carolina, among low-income persons. And by the way, most of the low-income uninsured are in 4 states: Texas, Florida, Georgia, and North Carolina. That is a lot of the low-income uninsured in the United States, just in those 4 states. So one of the goals of the Affordable Care Act was actually to have one national standard for Medicaid. So this is Medicaid eligibility across all the states. And you can see what's happened is actually the disparity has grown. And so if we look here in 2013, before Medicaid expansion, if we look at the states that have not expanded Medicaid and the states that have expanded Medicaid already had a lower uninsured rate. And that probably has something to do with their policies before the Affordable Care Act, as well as it might have something to do with the structure of their economies. But look what's happened over time. Those states that have expanded Medicaid have cut their uninsured population in half. While these states that have not expanded Medicaid, look where their uninsured population is. It's still very high. And so the disparity has grown. We don't have the United States of America in healthcare policy. We have Medicaid expansion states and non-Medicaid expansion states. And that makes a big difference. I mentioned COVID before. All these people who have lost their job through no fault of their own during a pandemic, lost their job, in many cases don't have health insurance. Well, in the states that expanded Medicaid, they were eligible right away for Medicaid. They were eligible for Medicaid. But in the 12 states that haven't expanded Medicaid, that option doesn't exist. And so it's really limited people's Medicaid eligibility. There's another disturbing pattern, and actually, let me go back to show you here. All right, so notice something. If I go back here and look, notice the uninsured rate's falling. Notice here in between 2016 and 2019, it starts to go up. And that's a problem because the US economy was pretty good during 2017 to 2019. We had a very low unemployment rate. We had decent economic growth. And in those circumstances, we don't expect the uninsured population to go up. And yet it was going up. Why did we have an increase in over 2 million uninsured? between 2016 and 2019, a lot of it probably has to do with some of the Trump administration's policies. The Trump administration did not believe in Obamacare, um, wanted to repeal Obamacare, as we mentioned, and adopted policies to really erode the Affordable Care Act. And those policies probably had an effect, and that's part of what's going on here in the uninsured numbers going back up. But that was a really disturbing trend because that was before COVID that our uninsured population was going up. To put a fine point on that, I would hope that no matter what political party you are, no matter what your ideology is, no matter which basketball team you root for, I would hope that we can agree that every child in this country should have health insurance. We know from evidence that having health insurance is important to children, is really good for children, not just for their health, but for their performance in school. So I think that's something we can probably agree on as a country, except we don't have universal coverage even for children. Now, the Affordable Care Act brought down the uninsured population in children, brought it down, you can see, to 3.5 million. But it's gone back up during that same time period. It went back up by about 800,000. And that is a really troubling trend, that we have such a significant increase in the number of uninsured children. And so it shows you how far we have to go. So let me just say a little bit about what do we know about the Affordable Care Act? Okay, it provided people with health insurance. What difference did it make for their health? So we have a growing literature, scholarly literature, trying to look at what difference does the Affordable Care Act make to health. And there are studies that are now showing that expanding Medicaid does save lives. And you can see here by this calculation, this is by a health economist, I believe, at the University of Michigan, that over the first 4 years of Medicaid expansion, they estimate that over 19,000 fewer deaths because Medicaid was expanded. More people, low-income people, got access to Medicaid. They got access to medical care, and it lowers their mortality. And as they said, if you look at it the other way, not expanding Medicaid means we probably had about 15,000 of additional deaths in the states like North Carolina that did not expand Medicaid. So there is growing evidence that expanding health insurance coverage, particularly Medicaid, can save lives. If we look at this more broadly, this is by another study that came out this past year, as they say here, there is evidence that there are promising improvements in certain health outcomes. Early stage cancer diagnosis, cardiovascular health, those are really important. But we're still limited. It's not easy to study the effects of health insurance on health. It's a very complicated endeavor. We're still limited in what we know. Some cases, as I say, we just don't have the data. When we ask people how are they doing in self-reported physical and mental health, the results we've gotten are mixed. Despite that, there is evidence that we're getting some mortality improvements from insurance expansions, and that the health benefits of the ACA are growing over time. And that's good news, because that's what we want. We want health insurance, people that have health insurance, because it provides financial security. We want them to have access to medical care. But if we can improve their health, that's a really good thing. And so we've got some reason to believe that that's going on. What about healthcare spending? What do we know about healthcare spending, and what has the Affordable Care Act done? Well, we spend a lot of money on medical care in the US, the most in the world, $3.5 trillion and counting. That's 2018. We're probably, the data lag, but probably in 2021, I would guess that we're getting right around the $4 trillion mark. So we spend a lot, over $11,000 per person, every person in this country. GDP is gross domestic product, size of the economy. So the way to read this is over 1 out of every $6 in the US economy is for healthcare. So healthcare is very expensive. And this is, if you just look down here from the Kaiser Family Foundation, this is the average annual premium for single and family coverage. And you can see how expensive it is. So for 2020, for this past year, the average price for an individual plan for somebody getting health insurance through work was $7,500. And for a family plan, so 2 spouses, 2 kids, family plan, the average price is $21,000. Think how expensive that is. Think about average income in the United States, average wages, and you understand why this is such a burden for so many businesses that can't afford to provide health insurance, and also a burden for many workers. I come with good news, and that is there has been a slowdown in the growth in healthcare spending. So this is showing you two bars here. The first one, the sort of lighter green here, that is the average annual increase in healthcare spending. Just how much does it go up this decade on average per year? So for example, the 1970s, some of you like me may remember the 1970s where we had a lot of inflation. Healthcare spending grew on average each year by 13%. That's a lot. The darker bar here is the increase in the gross domestic product. That's just the size of the economy. So this here means that healthcare spending was growing on average by 3 percentage points faster than the economy was growing. And you can see that's our experience historically. Healthcare grows faster than the rest of the economy if I go through this. But look what happens when I get to the Affordable Care Act. You can see that the first years of the Affordable Care Act, actually healthcare spending grew at a rate slower than the economy. And for the next few years, it grew at a rate only 1 percentage point faster than the economy. Now that's a really impressive achievement because remember, we extended health insurance coverage to 20 million people. So you would think, well, we're covering 20 million additional people. Is that going to add a lot of cost to our healthcare system? It really didn't. Actually, the rate of growth of healthcare spending went down even while we added 20 million people to coverage. Why is that? Well, first of all, a lot of those 20 million who got health insurance, they were already using medical care. Probably less medical care on average than they'll use when they're insured, but they were consuming some medical services. Secondly, the Affordable Care Act had a series of policies that we can talk about if you want to try and control healthcare spending. And some of those probably have worked. Some of them actually have worked to help slow down healthcare spending and worked probably in a way that is surprising to a lot of health policy analysts. In other words, worked better than we expected. And that's why we have much lower increases in healthcare spending than people projected back when the Affordable Care was enacted in 2010. But there's a flip side of this, which is if we could go out of our houses and do person on the street interviews and ask them, what do you think about healthcare spending? Very few people would say that healthcare spending is slowing down. And the reason is a lot of Americans don't feel it's slowing down because the way they experience it is not these big numbers I'm giving you on average. They look in part at their copays and their deductibles. What's happening there? They're going up. So this is the average deductible for one person. And you can see here, look at the top line for workers who have deductibles, which at this point is, over 85% of the workforce has a health insurance plan with a deductible. You can see that the average deductible is now $1,600 for an individual. That's the average. There are many workers who have deductibles that are $2,000, $3,000 and more dollars. So when I was giving this talk a decade ago, look where it was. The average deductible was $900. So one of the reasons healthcare spending may have slowed down in the private sector is a lot of companies went to higher deductible plans. And when people face higher deductibles, they don't use as much medical care. Now, the good side of that is it slows down the rate of increase in healthcare spending. The negative side of that is we know from a lot of evidence that people are lousy judges of when to come in and when not to come in and see the doctor. And so when faced with higher costs in terms of deductibles, co-pays, co-insurance, a lot of people don't go in for beneficial medical services or stop taking medications that are beneficial and jeopardize their health. So this transformation is think of it as a private revolution. We've changed the standard of private health insurance in this country towards high deductible health insurance. We didn't really debate it. There was no real national conversation. It's there, it's here. And it started before the Affordable Care Act. The Affordable Care Act didn't stop it. So the Affordable Care Act helped with the uninsured, but we still have a major and growing problem with the underinsured. Millions of Americans who are one illness away from discovering that their insurance isn't very good, and they could face very high costs if they or somebody in their family gets sick. So let me finally turn to the political performance now of the Affordable Care Act. And here, I think the Affordable Care Act has a very mixed record. So I want to give you this quote from Wilbur Cohen. Wilbur Cohen was a federal official who was in the Social Security Administration. He's one of the creators of the Medicare program, amazing, just amazing policymaker and influence in the 20th century on US social policy. And he was writing a piece a decade after Medicare was enacted and said, what have we learned? It changed America. It changed health politics in America. The ideological opposition to government's role in health insurance is done with. It's gone. And writing in 1975, you can understand why he said that, because prior to Medicare, there had been this big debate about should the federal government be involved at all in federal health insurance. And Medicare won that debate. We have Medicare, we have Medicaid. Those are enormous programs, and the federal and state governments are involved. On the other hand, what the last 10 decades show is there's still a lot of ideological opposition to a public role in health insurance. People thought that the Affordable Care Act would travel the trajectory of Medicare. Medicare was very controversial before it was enacted. After it was enacted, the partisan debate about Medicare, the ideological debate about Medicare faded away. It became popular, extremely popular with beneficiaries, with the public. There was a bipartisan consensus to improve Medicare over time. People thought that the Affordable Care Act was going to travel the same road. Yes, it was extremely controversial, but once people experienced the benefits, once they saw what it could do, once they knew they were dealing with the Affordable Care Act as a reality, not Obamacare as a myth, then it too would become popular. It too would draw bipartisanship. It too would be improved over time. That has not happened. That has really not happened. And let me show you some charts that speak to that. So one way, so sort of organizing principle to think about this is, in the last decade, neither Democrats nor Republicans got what they wanted in the Affordable Care Act. Democrats wanted to improve it. They wanted to build on it. The law passed in 2010 was never a final destination. They wanted to improve the affordability. They wanted to cover more people, and so on. They haven't been able to do any of that in the last decade. Meanwhile, Republicans wanted to get rid of it. Republicans in Congress wanted to repeal it. And they weren't able to do that either. And so really the last decade has been a stalemate in American health politics. The Affordable Care Act has been stuck in this sort of purgatory, unable to move really off of its original vision in 2010. When we look at public opinion numbers, it gives you a sense for most of the last decade of that stalemate. This is favorable and unfavorable. You can see the blue is favorable. The unfavorable is this burnt orangey kind of color. And you can see for most of the last decade, up until 2017, late 2017, the public was just evenly divided. It was just evenly divided. Now, the Affordable Care Act started to become more popular in 2017. Why? Did it improve its performance? No. Did they make any changes to it? No. The reason it became more popular is Republicans tried to repeal it in 2017. And when they tried to repeal it, a lot of people said, wait a minute, we don't want to lose it. And so it actually created more support for the law. And you can see that has continued. And actually, if we go, this is going all the way to either November, December 2020, you can see during the pandemic, opposition to the Affordable Care Act has gone down. And that is perhaps not surprising, because the Affordable Care Act has been there as a safety net for a lot of people, and it's during these difficult economic times. But notice that even though the Affordable Care Act has the most positive sort of gap here in attitudes that it's ever had, notice its popularity is still in only the low 50s. This is not Medicare. This is not Social Security. It just has not attracted that kind of coalition. And one of the reasons for that is the partisan split. So this is showing you opinions about the Affordable Care Act by people's political party ID. Look at the difference. Democrats About 80% have a favorable opinion of the Affordable Care Act. Republicans, it's 20%. Look at that partisan gap. It's an enormous partisan gap. And actually, we've asked other questions in studies, and they ask, has the Affordable Care Act helped or hurt you? And we get very different answers depending on people's partisan identification. And that shows you that Democrats look at the law with blue tinted glasses and they see a law that's working, that's essential, that's important. Republicans look at it with red tinted glasses and see a law that's a failure, that needs to be jettisoned. And so we have this huge partisan gap, and that's a big reason why the Affordable Care Act has not developed as strong a political constituency, as strong a public constituency as Medicare and Social Security. That partisan gap, just to detour ever so slightly into COVID, that partisan gap is unfortunately evident in the reaction to the pandemic. And so what you're seeing in this is the blue is Democrat, red is Republican. This is through August. Look at the difference in attitudes about who's worried about COVID and social distancing and masking. You see these big partisan gaps. And that, of course, is one of the things that has hamstrung our COVID response. A pandemic should not be a partisan issue. It should be about public health, about us coming together as a country. And yet the pandemic has torn us apart at the individual level, at the state level. So that same polarization that you see in the public around the Affordable Care Act, the point is, it's not just about the Affordable Care Act. We live in a time of increasing partisan polarization. And it's not just in the public, it's in Congress. All right, so what you're looking at here is the House of Representatives. And this is, and by the way, I should have said this earlier, I am so distractible, so I'm going to answer questions in chat at the end, but if I stop in the middle of this, I will implode. I'll just go off the rails. So I feel free to ask questions in the chat and Q&A, and I'll get to them at the end. So, all right, what you're looking at is the scale of ideology. Higher up is more conservative, lower down is more liberal. This is the average ideology as measured by a team of esteemed political scientists of Republicans versus Democrats. So to read the chart, let's go to 1945. All right, Republicans are here. Democrats are here. Republicans are higher up on the scale. They're more conservative than Democrats in Congress. Thank you very much to political science for showing us something we already knew. We're really good at taking simple things and making them complex. But notice that the gap between Republicans and Democrats isn't enormous ideologically, and particularly between Southern Democrats. And of course, the South, we're running a racist apartheid system where Black Americans could not vote. And there was one party rule. And Southern Democrats in Congress were very conservative. So you can see there's not much of a gap there. Now look what's happened the last 4 decades. Republicans in Congress have become a much more conservative party, and Democrats have become a bit more liberal. Now look at the ideological gap. It is enormous. It's bigger than at any point, well, since the 1870s. That's right after we fought the Civil War. And it's actually a bigger gap than even then. It's the biggest gap we can measure. The biggest gap we can measure is right now in contemporary American politics. A huge divide between the parties, and that has really affected everything about Obamacare and the politics of the Affordable Care Act. So it's not just that the public is divided, it's even more so that Congress is incredibly divided between Democrats and Republicans. It's not just ideology. So this is, I don't know if I got like a buy one, get one free sale on political science charts, but I'm showing you another one. So this looks complicated, but it's not. What it's showing you is the average of the Democratic Party's share of the two-party vote averaged across the presidency, House, and Senate. So during each decade, what percentage of the vote are Democrats getting compared to Republicans? And so you can see in these periods, like the 1860s and 1870s that are in red, these are heavily Republican eras. That means Republicans are winning national elections. The 1930s, Franklin Delano Roosevelt, okay? Or the 1960s, Lyndon Johnson. Democrats are winning in these decades, the presidency and Congress by big margins. See this down here? 1990, 2000s, 2010s. We can now add the 2020s. Notice this is really close to zero. Zero would mean there is basically a 50-50 vote between Democrats and Republicans and what percentage of the vote they're getting for a president, House, and Senate. We're pretty close to that mark. And this has no historical precedent to have this many decades of close elections together. Why does that matter to healthcare? Well, when you have really close elections, it means that the party that's out of power, the minority party in Congress, has an incentive essentially to mess up the party that's in power and try to stop everything they do and not cooperate, because you can see that you might become the majority party without that much of a change of a vote. So in other words, when you have this level of competition in elections, it feeds obstructionism in Washington. And so another reason that Democrats and Republicans are so polarized is it may not be just ideology, it may be power. That our elections are so close in this period that each party believes it can't give any quarter to the other party in Congress and has to try and ensure that their agenda fails. Keep in mind, when the Affordable Care Act was enacted, not a single Republican voted for it, not a single one. And when President Trump tried to overturn the Affordable Care Act, not a single Democrat voted for that legislation. So we have that level of polarization in voting on healthcare. The natural course, we talk about the natural course of disease, there's a natural course of public programs. The natural course of programs is like Medicare, there might be an existential fight over the program, lots of controversy, but after it's enacted, we go to a different stage where there's incremental improvements to the program and often bipartisan. One party learns that, okay, we can't get rid of the program, and the other party learns, well, the program's got problems. And so they come together and they do things together. It may be hard to believe, but there was a time when Democrats and Republicans collaborated quite regularly to improve the Medicare program. The Affordable Care Act has never followed that course. It never went to the second stage. We're still in the existential stage, still fighting over its existence. And so the result is there have not been incremental improvements. There have not been repairs to the law over the last decade. Bipartisanship has been non-existent. There have been a few cases where Democrats and Republicans have come together to subtract things from the Affordable Care Act, to take things out. But there has not been a single case to date where Democrats and Republicans came together to add something to the Affordable Care Act and enhance it. And again, that speaks to the polarized politics that we live in. Bipartisanship is a unicorn. It's something everybody talks about and wants to believe in. It doesn't really exist when it comes to the Affordable Care Act. All right, so let me turn now to the Biden administration. And a reminder, during the presidential election, what was Joe Biden's health plan? What did he talk about? All right. Well, he wanted to build on the Affordable Care Act. He was part of the Obama administration, wanted to keep Obamacare and keep much of what we have today. But he wanted to make the Affordable Care Act more affordable. So improve the kind of premiums that people get, these tax credits that help them buy private insurance, and also help people who are middle class afford coverage. So he wanted to improve it. He wanted to extend Medicare eligibility to age 60. So it's at 65 right now, wanted to go to 60. And then he wanted to, either try and get those states to expand Medicaid that haven't expanded yet, or alternatively, create a new option, a new public option. So not part of Medicare, but Medicare-like, meaning a federal government-run program, a new insurance program, a public option, and people could join the public option under the Biden plan if they were uninsured. And if they were in a state that didn't expand Medicaid, they could join it and there would be no premiums, no copays, no cost to them. And that would be a way he hoped of picking up a lot of low-income uninsured. The public option in his plan during the election campaign also would have been available to people who had private insurance but didn't like their private insurance. They could also choose to leave it and join the public option. All right, so that was his plan. What do we know? What's the reality? Gosh, we're not even a month in the administration, but what do we know so far? So Joe Biden's been really busy issuing executive actions. Donald Trump issued a lot of executive actions, and Barack Obama issued a lot of executive actions. I think Biden's on a record pace, but the reason you're seeing so many presidents issue executive orders and do things administratively is because there's so much stalemate in Congress, and it's so hard for them to get things through Congress that they're just doing what they can unilaterally. So what has the Biden administration done so far? Well, the marketplaces where people can go and buy coverage, generally there's an open enrollment season only once a year. And when the pandemic hit, a lot of people appealed to the Trump administration and said, please open them up right now, because we're fighting this pandemic. We have so many Americans who are losing their jobs, who are losing their health insurance, who are in dire straits. Let's give them a chance to sign up for coverage. The Trump administration refused to open up the marketplace. It is now open. This week it opened back up. So once again, people across the country can go in, and if they don't have coverage, can go in and sign up for coverage. And there are a lot of people out there who are eligible for financial assistance who aren't insured right now. The Trump administration really curtailed the advertising around the Affordable Care Act and around advertising, telling people that they were eligible for these options, that there are these health insurance marketplaces where they could get coverage. The Trump administration almost zeroed out that advertising. The Biden administration has reinstated it, and they're going to try outreach again. The Trump administration introduced work waivers in Medicaid. So states were allowed to apply for waivers, and they can impose work requirements on their non-disabled, non-elderly enrollees in Medicaid. This was very controversial. The Trump administration and some states said they wanted to give people incentives to work, but the estimates from those states showed that if these work waivers went into effect, we would really increase the uninsured population. In Medicaid, they've been hung up in the courts. Only one state, I think, Arkansas, actually implemented this to any extent, and they did increase their uninsured population. The Biden administration is rescinding that. States aren't going to be allowed to do that anymore. Other actions they could take that are, either very likely to happen or potentially likely to happen. There's something called the public charge, which has to do with immigration, and it has to do to access to getting a green card, and limiting access to getting a green card if you use certain public programs. And one of the reasons the uninsured population probably has gone up the last couple of years has to do with this public charge regulation. And it turns out that a lot of immigrants in the United States who are legal immigrants, so they're legal immigrants, were afraid that they would run afoul of this new regulation. And so maybe they didn't sign up for coverage that their children were eligible for, who may have been born in the United States and were eligible. And that may have helped to drive up the uninsured population. It certainly has driven up the uninsured population among Hispanic Americans. So the Biden administration has said they've ordered federal agencies to look at public charge. And I think when that process is over, they're likely to reverse the Trump policies on that. There's something else called a family glitch. I won't go into the technicalities of it, but it's basically a problem with the Affordable Care Act where if your spouse has health insurance through work, but their employer doesn't subsidize them for spousal coverage, so they have a good subsidy as a worker, but the family plan doesn't have a lot of subsidy, you still can't get any help with that through the Affordable Care Act to get subsidies to help you afford coverage, even though it would be unaffordable for you. So maybe they'll do something about that. The Trump administration really supported these short-term kind of health plans that people buy. The reason they supported them is they're not subject to all the Affordable Care Act regulations. They're sort of outside of the orbit of the Affordable Care Act. The Biden administration may choose, I don't know, to retract those deregulated plans. And something else the Biden administration can do, which is use federalism, use states, and approve waivers for states that want to try interesting things that build on the Affordable Care Act. What about in Congress? What about in Congress? Well, we're in early days, but we do have some legislation, particularly in the House right now. And are some legislative provisions that have been included in the COVID relief bill. Whether they stay in the COVID relief bill, we'll have to wait and see. But for now, some of them are in there. And so Democrats in Congress have proposed extending those subsidies we talked about before to help people buy private insurance who are middle class, who right now, if you make $50,000, you don't qualify for any financial assistance to buy health insurance, even though that insurance, particularly if you're older, can be very expensive. And so this would extend subsidies up to higher income levels. It would also improve the generosity of those subsidies for lower income Americans. So you saw how high some of those deductibles were. That would go down under this legislation because the subsidies would be higher. And so people would have lower copays, lower deductibles. There's also some legislative language that would try and re-incentivize the states that have not expanded Medicaid by giving them new financial incentives, essentially more money from the federal government if they expand Medicaid. So these are all things that Democrats in Congress are drafting in the legislation right now. Again, how much of this makes it in the COVID relief bill? We don't know. If it doesn't make it into the COVID relief bill, it's quite possible it's going to be done as separate legislation down the line. What about the public option? That was one of Joe Biden's provisions. What about expanding Medicare eligibility to age 60? There, the administration really has a tougher road to hoe. And the reason is the majority in the Senate could not be any slimmer. It's a 50-50 Senate with, of course, Vice President Harris breaking the tie. And so to pass anything in the Senate, they need all 50 Democrats. And it's not going to be easy to get all 50 Democrats for more ambitious agenda items. So you have senators like Senator Manchin from Arizona, Senator Sinema from West Virginia, Senator Sinema from Arizona, who are not liberal Democrats. And they may not be too thrilled with the idea of a big new government public option federal insurance program. And if they don't support it, if even one of them doesn't support it, it's over. You can't, you're not going to pass it because you don't have 50 votes. Could you get a centrist Republican? Well, maybe for some parts of the Affordable Care Act, repair legislation, let's call it. Maybe so, for improving the subsidies. But for something like the public option, it's going to be hard to get Susan Collins or Lisa Murkowski or somebody like that. There's just a very limited reservoir of Republicans who are going to be willing to go along with Democrats, and some of these ideas are just going to be too liberal for them, too big government for them. What about expanding Medicare eligibility? I think that's an interesting one. It might be more possible than a big public option with this current Congress. It's very popular with the public, so maybe Senator Manchin and Senator Sinema could get behind it, but again, not going to be easy and probably an uphill fight. One other wildcard I just want to mention, another name for the Affordable Care Act is the Lawyer Full Employment Act of 2010. We've had a decade of legal cases, and every time we have a challenge the Affordable Care Act, people say, well, that's the final case, and it's never the final case. We've got another one, as you know, before the Supreme Court right now. It's California versus Texas. It sounds like a good football game, but it's actually a Supreme Court case. And so you can see here the different states have taken different positions. And essentially what this case is about is these orange states, well, they're colored in orange, they're Republican governed states. The state attorneys general in those states are challenging the constitutionality of the Affordable Care Act based on some changes that Congress made in legislation a few years ago. And in the blue states are defending the Affordable Care Act. Most legal scholars think this case does not have any merit. When oral arguments were heard a few months ago before the Supreme Court, it didn't seem like the Supreme Court majority was sympathetic to it. But we don't know. Until they issue a decision, we don't know. The significance of this case is if the Supreme Court ruled in favor of the plaintiffs, in favor of Texas and these other Republican governed states, they could potentially rule that the entire Affordable Care Act is unconstitutional, illegal, and we would have to get rid of the entire law. So there's, again, I think the conventional wisdom, which is often wrong, I should note, is that the Supreme Court's going to uphold the Affordable Care Act and reject this suit, but we don't know that for sure, and we'll find out in a few weeks. What about longer term? And I think one of the mistakes we make is we make political projections, and people are always asking me to predict the future. And I went to school for political science, but they didn't teach me much about fortune telling. And we tend to just extrapolate from the present because that's what we know. So what I told you about what can happen and what will happen is good through 2022. But in the end of 2022, we're going to have another set of elections. They'll change the composition of the House and Senate in ways that we can't predict right now. And we could get a Republican majorities in the House and or Senate coming out of the 22 elections. And if we get that, it will mean the Biden administration can't do anything legislatively. Or maybe it expands the Democratic majority slightly. And that uncertainty is even higher when we think about the 2024 presidential elections. So when we're thinking about what the world will look like in 2025, I've got no idea. I'm just trying to get through 2021 like the rest of you. But when we think about bigger ticket health reform ideas, like the public option, bigger kinds of changes in American healthcare, they're really dependent on what the elections produce. And we don't know what they're going to produce. So I would say there's a lot of uncertainty going forward. And this debate we've been having about American healthcare, which goes back now a century, it's not over. And the only prediction I can make is it's going to keep on keeping on. So I will stop there, and I'm happy to take questions. Max, how do you want to do?
I will go ahead and read the questions to you, but first I just want to make sure you can hear that applause.
Oh, thank you. I can hear you, Max. Yes.
Yeah. So everyone else out there is doing the same. Thank you so much for that excellent presentation. I do have some questions. I want to encourage everyone to use the question and answer button at the bottom. I would just want one observation here, just to say, recently I'm over 50 and I went for your standard checkup and your standard tests of blood tests when you hit over 50, and to come and get a bill for $396 for what seems like something that is absolute, and of course that's only a portion after insurance. I just wonder, what is might be the cumulative effect of people underusing their insurance? I mean, it gives me pause. Do I go and get my shoulder, which is a little crazy, and I think a lot of people make these decisions. Can you see any financial cost of this projected out into the future for people, who have insurance but aren't using it as much as they could?
Yeah, it's a great question, Max. So, I'm over 52, and I said to my doctor, I thought I was going to age like wine. And it turns out it's more like vinegar or something. I think I'm expiring. I'm spoiling, Max.
Wine is in the 30s and 40s. You're now turning.
Yeah, it's just not getting better over 50. So it's a great question. So there's a really important study that just came out in the last 2 weeks from some health economists out of Harvard and other places. And they looked at the Medicare program, Max, and they found that if we look at Medicare beneficiaries who all have insurance, a $10 increase in the copayment, so just $10 and what they had to pay for medications, right, led to about a 29, if I'm remembering it right, 29% drop in utilization and over 30% increase in mortality. That is an enormous mortality effect. We do not find mortality effects like that in health policy ever for anything. And so what they found is, even when we increase copayments slightly, a lot of Medicare beneficiaries stop taking their cholesterol medications and stop taking their blood pressure medications, and they died. That's what they found. So we historically in the United States have been really obsessed with the idea of overutilization, of the fact that because people are insured, they go in too often to the doctor. And we do have lots of evidence showing in many cases people overutilize in the sense that they go in for circumstances where there's nothing we can really help them with, and yet it costs money. But the flip side of that is we've been kind of blinded to underutilization. And what I think a growing body of literature is showing is there is a real cost to that. There's another study showing that when they increased co-payments for retirees out in California, it reduced their prescription drug costs, but it increased their hospital costs because more people got sick and got hospitalized. So somewhere in there is a balance, but we've got to think much more carefully about underutilization. We've got to get away from the idea that treating patients like consumers and exposing really sick people and people with chronic illness to out-of-pocket costs is a default good policy, because in many cases, it's actually probably not a very good policy.
Well, thank you for answering that. And thank you also for taking on that copay for me. I really appreciate that.
My pleasure.
I have Tom Taylor has two questions, and I'm going to see if I can combine them. Tom Taylor asks, do you predict the elimination of the mandate would lead to a premium death spiral? And then he also says about a graph that you were talking about around 4:17 p.m., if you could remember. Your graph shows significant, albeit minority opposition to the ACA. What portion of those opposing the ACA do so because they favor universal health insurance? So I guess the first question is about elimination of the mandate and premiums, and then the other.
Great questions, Tom. And Max, I'm glad you remember where I was at 4:17, because I floated off somewhere. This is a problem for those of us who spend our lives on Zoom teaching now. When I'm in person, I can just kind of go into dreamland, and I don't think my students notice. But on Zoom, it's no good. So you're right. There are a portion of people who have an unfavorable view of the Affordable Care Act in those polls I was showing, because they favor single payer, Medicare for all, something like that. And so their view is unfavorable of the Affordable Care Act, not because they're opposed to the government and health insurance, but actually because they want more government and health insurance. That, of course, it's mainly on the Democratic side, but some independents as well. I can't remember off the top of my head what portion it is, but it is part of that unfavorable rating. Absolutely excellent point. In terms of the mandate, so just so everybody understands Tom's question, the Republican majority in Congress in 2017 eliminated the penalty for not having health insurance. The Affordable Care Act had a penalty in there, and the logic of the penalty was at least twofold. One was that we wanted healthy people to sign up for coverage. If we regulated insurance and we told them they can't turn away sick people, and gave them subsidies to buy coverage, then the people who were going to show up to buy coverage were people with pre-existing conditions, which is great, except it makes for really unstable insurance pools. We need healthy people to balance it out. So the mandate penalty was supposed to incentivize healthy people. And the idea was also that, this is sort of a program, something like Social Security or Medicare, that everybody should contribute to. The Republican Congress in 2017 zeroed out the penalty. So there is no penalty for not having health insurance anymore. A lot of people predicted at that time that it was going to destabilize the private insurance markets. It has not happened. Actually, they're in better place in 2021 than they were when this was zeroed out. So we're still trying to understand that, and it still may have more effect over time, but part of it's an informational story that it turns out a lot of Americans thought the Affordable Care Act was already repealed. So it made no difference to them because they already thought it was repealed. Some people don't know the penalty is zero, even still today. So we've got some confusion here. But also, I think what the evidence shows so far is that as long as you have those subsidies for health insurance, a lot of people will buy coverage. If you took the subsidies away, then it would be a different story. But if you maintain those subsidies, then those markets can stabilize. And we'll see going forward, but so far that's been our experience.
Great, thank you for that. Niels Brubaker has two questions. I'll take the perhaps the most cut and dry one first. Is how do we pay for all these additional subsidies? The deficit is already through the roof. And then he goes on to ask, I actually asked this earlier, but are there any plans in the administration or Congress to lower the cost of the ACA to both insured and to the US budget by lowering medical costs, which are driving high premiums and deductibles? So the first one is, how do we pay for it? And then
Yeah.
what about the costs? And can we do something about that?
So it's a great question about paying for it. I think in the short term, the legislation I described, which is short-term legislation, it's part of the COVID relief bill. So it would only last, those changes would only last for a couple years. I think they're thinking about this as COVID relief in the sense that they're putting this money in the economy and they're not going to pay for it. And as you rightly point out, the deficit is enormous right now. On the other hand, there's been a real sea change in how economists in the United States think about the deficit. And a lot of economists in the United States now are comfortable with really large deficits and think that large deficits, particularly during a recession, particularly during a pandemic, are actually something that is a good thing. Now, over the longer haul, I think is the question. So let's say that legislation goes through, it doesn't go through. Let's say they want to make these changes for a decade. How are they going to pay for those changes over a decade? If they want to do them over a longer haul, then they're probably going to have to find what they call in Washington some kind of offsets. And then we'll have to see. They're going to have the usual set of choices. And the usual set of choices is increase taxes on somebody, take money from something else and reallocate it, or add to the deficit, or create a new financing mechanism. And we'll have to see which one of those they pick. There has been basically no budget discipline in Washington over the last 4 years, none. And at the moment, I don't think there's a lot of appetite for it, but we'll see once the pandemic fades if that changes. In terms of the cost of healthcare, so you're quite right that there are many reasons why U.S. healthcare is so expensive, but one of the central reasons is we have the highest prices in the world. We just have extraordinarily high prices, and there is growing attention to this in the health policy community that, hey, we're paying way higher prices for the same exact things as people in France and Germany. Trying to lower those prices is not easy politically because those high prices mean higher income for the pharmaceutical industry, for the medical device industry, for hospitals, for doctors, for everybody. So lowering prices is fraught politically. The Biden administration so far is focused on lowering the price to consumers. So they've got things in his presidential plan and in what I described that lowered the price to consumers in the sense that if the stuff passed, a lot of people's deductibles would go down. Some people's co-payments would go down. So that would make it more affordable. And if they were able to pass a public option, which would have the market power to negotiate lower prices, then that public option would probably offer more affordable coverage for a lot of people. But in terms of centrally taking on higher prices, that is not part of the Biden administration agenda. To do that, then you have to start looking at much more controversial proposals for which there's been very little appetite in Congress to date.
Great, thank you for that. We have a question here from an anonymous attendee. It's a good question. Why? It starts out with a sort of a preface. Why would any state think it makes public health sense to deny COVID vaccinations to our undocumented residents? But the second part of this, I think, is something to just address in general. Will immigration reform allow for access to healthcare? And I will just add, what can you speak about immigration reform and its relationship to the healthcare debate?
Great questions. Immigration is tied up with healthcare, and the COVID pandemic has shown a lot of things. And one thing that it shows is that it doesn't matter if you're a U.S. citizen or if you have a green card. The virus doesn't know what your citizenship status is. The virus doesn't care if you're documented or undocumented. And in order to combat this, we've got to vaccinate everybody. We've got to get access to treatment for everybody, because if we do not do that, the virus is going to unfortunately continue to fester. Now, in theory, when people go in for COVID vaccinations, the government's paying for these vaccinations, even if you're uninsured, they're not supposed to be asked about their immigration status. And so in theory, this shouldn't be a barrier, but in reality, I certainly have heard some stories of Spanish-speaking North Carolinians who were documented and had made appointments and so forth. And they went into the vaccination sites, and nobody was there who spoke Spanish. And there were sort of barriers, linguistic barriers. Other people were afraid to come out of the shadows, so to speak. So it's something, you're right, that we've got to work on in the vaccination. The broader issue, look, if we could reform the immigration system, which is, it makes healthcare reform look like I think like an easy, easy thing. If we could really do a comprehensive reform of the immigration system, it would change healthcare access, because the uninsured rate among unauthorized, undocumented immigrants is very high. It's extremely high. And if we could give a path to citizenship or reform immigration, however people want to reform it, then yes, we would create more access. And I think what COVID teaches us is it's not us and them. When it comes to these kind of public health issues, we're all in it together, and we have a strong incentive in terms of public health of giving everybody in the United States access to health insurance and medical care.
Just out of, it really seems, did our healthcare system contribute to deaths in COVID last year?
It's a great question. I think the short answer is probably yes, but there are a lot of contributors. We had really poor leadership in Washington, a lot of bad decisions made in a lot of states. We have a cultural aversion to being told what to do, and less compliance with mask wearing than certain countries. The fact that we have a federalist system between the federal government and state government caused some confusion. And it's also the case that there are some countries with universal systems that really struggled. I mean, Great Britain is as universal as it gets, and they've had a terrible COVID experience. I think next to us, they're sort of right there. So I think US healthcare, certainly, we don't have a system, Max. We have a non-system. And the fact that we have a non-system has created barriers. Let me just add quickly one other point on that. So I've got a friend in England. I talk to him all the time, one of my best friends. And because they have a system, the way they have one of the higher vaccination rates in the world. And one of the reasons they do is they have the National Health Service, and they have centralized way of contacting everybody. And so they contact you and say, okay, you've got an appointment and so forth. Here, people are finding out about vaccination availability willy-nilly and based on their information networks, and it's worsening disparities. Black Americans aren't getting the same access to vaccines as white Americans. Latino Americans aren't getting the same access to vaccines as white Americans. And so the fact that we have this non-system creates some barriers for us. It probably did add some to the death toll. But if we had had better leadership and handled this in a different way, I think we probably could have had a better outcome, even with our non-system.
We have a question here, and it's from our esteemed colleague right here at Carolina Public Humanities, Paul Bonici, who asked, why didn't we use Medicare to contact people?
Well, so the problem is not everybody's in Medicare. So Medicare could and can contact people in Medicare. But even then, although Medicare is a national program, there is some behind the scenes devolution at the down at the regional level. And then we've got, even if we did that through Medicare, what do we do about the other 250 million people? And so it's just, it's the contacting and communication has been so fragmented, which is really just a mirror and a reflection of what we have generally.
Well, I would just say we have a couple minutes, folks, if you have any other questions. And I would just, if there are any questions, go ahead and put them in. John, is there anything you didn't get a chance to say that you're thinking about? What are your hopes? You can leave the expert world if you want and just sort of talk a little bit about what you might envision in 2040 if you were to design a healthcare system.
Oh, 2040. Well, so, I mean, first of all, I would say in the short term that even though we have an evenly divided Congress, I think there are things the Biden administration can do that will make a difference, that will get more people covered, more people access to health insurance, and make coverage more affordable. So I think it's important to realize that even if a fully ambitious agenda can't be realized in the next 2 years, a lot of things are happening that are going to make a difference to a lot of people. If you look at where we were in 2008 and 2009, in terms of just health insurance, we're in a much better place. We're in a place where people can't be denied coverage because they have a pre-existing condition. We're in a place that if people are struggling financially, we have options for them now. If they lose their job, we've got a way for them to get health insurance. So we're in a much better place. I'd love to be able to wave a wand, or maybe, can Harry Potter be elected president, Max? I don't know if he's a US born citizen.
I don't know what party he's in, so.
I don't know, a Hogwarts party. I'd love for somebody to wave a wand and clean up everything we have. It's going to be hard to do, but I hope that we can just keep making progress however we're going to make it. If that means incremental, fragmented progress, then let's keep making progress and keep heading in that direction of universal healthcare.
Well, I have, Jerry Everhard gave me a sort of a half question, but I think I know where he's going with this. Jerry wrote, are there features of other nations' healthcare that, and I'm just going to fill it in for Jerry if I can, that you might pick and choose or might think are things that we could implement into our healthcare system?
Sure, and there's a great documentary by the journalist T.R. Reid called, I think it's Sick Around the World. Maybe Paul can Google it. It's actually, I think it's on, you can find it on YouTube, or it's a PBS documentary, Sick Around the World. And he visits Germany and Taiwan and Great Britain and Switzerland and Japan. And thank you. It's a really, actually really good 1 hour, easy to understand look. So there are lots of things I would take from those systems if I could. They're much simpler administratively. We waste so much money in administrative costs in the United States. I haven't met an explanation of benefits, Max, that has made me any healthier in all the years I've lived. So we waste a lot of money that we spend on medical care is not for medical care. It's for administration. These systems are all much administratively simpler. They leave nobody behind. They are truly universal. Even in a country like Switzerland, which is quite a conservative country politically in many ways. So I would borrow their universalism. Somebody asked about prices and cost before. They all do variations of a form of cost control that really involves price regulation. We don't have it in the same way in the United States. We have fragmented price regulation. Maryland is a state that is experimenting a bit more holistically with this. So I would borrow all those things if I could. There's no one system out there that's perfect, but there are a lot of other countries that do things well.
You know, John, I spoke to you about this, I think the last time we had you come and talk about healthcare, and that is that there is this discourse that the United States, we pay so much in healthcare. I mean, in particular for pharmaceutical products, we pay so much more than other countries. And I've seen charts where the averages are 3-4 times as much in some cases, sometimes 7 times as much, depending on the drug. And the reason for that is that there are price controls there, but there are no price controls here for the same exact price. And I had suggested to you, well, wouldn't an America First sort of discourse or rhetoric help convince people, why are we subsidizing other people's healthcare systems? Can you address the accuracy of just the rhetoric that I just threw out there, and whether that's some way of kind of positioning this?
Yeah, so there's no consensus on that. I mean, the Trump administration, maybe they heard you, Max, because President Trump was not a fan of the pharmaceutical industry, and he tried to mobilize that rhetoric to do some price regulation towards the end of his term in pharmaceuticals. So we want innovation in pharmaceuticals. And it's true that drug companies can charge more in the United States and do charge more in the United States because we don't regulate it as much. I think what a lot of the experts would say is there is a way for us to make sure there's still investment and innovation, but do a more careful job than we do right now in terms of regulating prescription drug prices and thinking about how we pay for it, because a lot of people right now, all the cancer patients, lots of people are faced with absolutely unaffordable bills for prescription drugs. And there's some room there for us to emulate what other countries do and yet still leave some of that innovation in place.
Great. Well, thank you for that. As always, it's complicated, isn't it? And
yes.
We really appreciate your expertise, that you live in this world and look at this and are working towards solutions. Again, I want to thank you, John, for your work here today, but also your work in the Department of Social Medicine, how important that is. And I want to thank you for coming and doing this. It was fantastic. Once again, can you hear the applause out there?
Yeah. Well, thanks for having me. And I am happy to come to any talk where BB King is the lead in.
There you go, Dr. John and BB King. So it was a double.
Just keep playing the BB King for an hour and I'll
All
be
right,
happy.
fantastic. Well, thank you all for coming today. And I just want to remind you folks, Lunch with Friends and Strangers will be talking with Charlene Register and talking about the life of Dorothy Dandridge. And of course, next week we have another Humanities in Action, and go to humanities.unc.edu to check out all of our programs. John Oberlander, thank you. Thank you, Paul, behind the scenes, and everyone for joining us today. It's been a great pleasure. John, last time I saw you, it was live in the Carolina Inn and there were people around and you had a drink in your hand. I hope that could be the case sometime in the future.
Let's do it.
All right. Thank you all for coming. We'll talk to you next time. Bye-bye.